Very excited to have finally gotten Dr. Eli V here. I'm not even going to try to pronounce his last name. Been only trying to get him here for over a year. So Molly, my first student, is going to be really sad because a lot of her work, she read a lot of Eli's papers. But Eli is an associate professor of biomedical and mechanical engineering at Virginia Polytechnic Institute. And he's been working on hypo and histotrypsy for a while. So we met as a grad student at a conference. He was at University of Michigan with the histosonics group, and he worked in histosonics for a while after he finished, and then he moved on to the B lab at Virginia Tech. So this is our first CAV seminar for biomedical acoustics, like I said. So thank you all for coming, and without further ado, I'll turn it over to Dr. V.
All right, well, thanks for the great introduction and for the invite. I've really enjoyed the visit here so far. A lot of great conversations, great to see the labs and talk projects today. So I will jump into it. So today I'm going to be talking about our work with histotrypsy. Forward. Just before I do, just initial disclosures are, thankful for our funding sources and some of our industry partners that we continue to work with, and you'll see some of that work in our clinical study. So brief introduction. I think I don't have to do this because I already heard it, but my background is in biomedical engineering. I did my undergrad at Michigan Tech and then did my graduate work. And I need to add that up here. I got a Michigan Tech here, so the slide got a little jammed. But and I went to University of Michigan where I worked in the histotrypsy lab there. I'll be presenting some of that work on like the groundwork of the fundamentals of histotrypsy and the development for liver cancer. I then worked at Histosonics for 2 years, translating this into our first clinical trials. And then now I run our lab at Virginia Tech. So my lab has, broadly speaking, we work in 5 primary areas, all centered around focused ultrasound. Histotrypsy, which I'm going to be talking about today, is the first non-invasive and non-thermal focused ultrasound ablation method. We also do a lot of work developing acoustically active nanoparticles, so gas-filled and fluid-filled particles for a variety of applications. A big one is targeted ablation of metastatic disease for breast cancer, as well as some different physics studies with these particles. We use some low-intensity focused ultrasound for reversible neuromodulation, both in small animal models and the collaborator who's doing some human work looking at things like treatment-resistant depression, anxiety disorders with focused ultrasound. Some work in biomaterials, acoustically active drug-releasing hydrogels. And then finally, we did some non-biomedical work for developing tools for rapid DNA extraction from plant, timber tissues, and more biologic tissues now. But in the interest of time, and we'll see how I do in time in general, because I have a lot of slides today, I'm just going to focus on our work with 50/50 based on the interests here. Hopefully that'll be a good fit. But I am happy to follow up with anybody who's interested in some of those other applications afterwards. So first, I want to just kind of talk about the histotrypsy overview of what it is, mechanism of action. I'll talk then a bit about some of the different parameter studies we do to characterize histotrypsy under different parameters. And then at the end, I'll talk about, or somewhat halfway through, I'll talk about some of our translational efforts, taking this for treatment of liver cancer as a first clinical application, followed by, I'll quickly run through some of the new clinical applications that we're working on in our lab at Virginia Tech. So the main features of histotrypsy, which we'll go through today, are histotrypsy is really the first completely non-invasive, non-thermal, and non-ionizing ablation method. And because of this non-thermal mechanism, there's some very unique features that come out of it. So what we're doing is we're generating really precise acoustic cavitation bubble clouds, and this allows us to get really precise ablation of tumors or other soft tissues. You can see on this histology image on the top right, this really sharp boundary between treated and untreated tissue that's characteristic of histotrypsy, and something you wouldn't see with like a thermal ablation modality, where you have kind of a centrally treated region followed by some partially treated tissue and untreated tissue around it. We also can see, because we're generating these cavitation bubbles on ultrasound imaging, we can see in real time where we're treating. So real-time ultrasound image guidance is a big feature that allows us to apply this to different applications with high precision in the clinical setting. We've also seen that we can use this, and I'll talk a bit about differences in tissue properties today, but for tissue selective ablation. So ablating tumors in regions near critical structures, near blood vessels, bile ducts, nerves. This is something that's really allowing us to not only make a improved ablation method, but also advance it to patients that currently don't have options because surgical or current intraoperative techniques are too dangerous for tumors located in these regions. So briefly, we've kind of in the field have three different types of historypsy, broadly speaking. There's some additions you could add on to this, but in general, we think of going from shortest to longest pulses being intrinsic threshold historypsy, so using single cycle pulses with a single large negative pressure phase. Shock scattering historypsy, which uses multi-cycle pulses, typically about 5 to 10 cycles, up to 20 cycles to generate a dense bubble cloud through a process called shock scattering. In that case, you're generating some initial bubbles at the focus with the negative pressure of your wave. You're basically scattering the shock wave off of it, it inverts, and you're creating a very high negative pressure to generate this dense bubble cloud. And then boiling historypsy, which is using millisecond long pulses to rapidly heat the body or heat a region of the tissue up to 100 C, nucleate boiling bubbles. For the purpose of most of my studies today, I'll be talking only about historypsy with single cycles. There's some unique features of the physics of this that we tend to study. You can see some examples of our acoustic pressure waveforms here. There will be a couple sets of data where I mentioned some of our work from multi-cycles and shock scattering. But just to keep things a little more concise, we'll focus mostly on what we're working with now, which is using these single cycle pulses, which require the highest pressure to generate cavitation in our application, but allow us to really control with high precision. But once we generate these bubble clouds with historypsy, the mechanism that we're damaging tissue is going to be the mechanical effects of these bubbles on the adjacent tissue matrix. And we'll talk a bit more about this as we go, but here's just an initial example of what a historypsy bubble cloud looks like. And this is, in this case, this is in an agarose tissue phantom with a layer of blood cells. And one of the key features you're going to notice here is that even after here, we've completely ablated this region, you don't see any spread out of that volume. So you have high predictability and high precision. Only the regions that are exposed to this cavitation are being destroyed by the tissue. So we've done some different studies looking at how are these cavitation bubbles in a bulk tissue breakdown process working, starting with some simple single bubble models. And what we see is during bubble expansion as well as collapse, we're exerting very high stress and strain right around that bubble wall. And you can see from the plot on the right, as you move at the distance away from the bubble wall, even within hundreds of microns, pretty much all that stress that you're inducing on the cells has dropped off. So this helps to explain why we think we're getting very precise lesions that aren't causing big damage outside of the region around these bubbles. It's really localized around each of these bubbles within this cavitation cloud. So we've done some work. We've built some microscope transducers. You can see here, this is built onto the stage of a inverted microscope. And then we exposed some layers of breast cancer cells, in this case, to these. And this is using a high-speed image. And just for reference, you can see on the bottom here, really the high rates of this, bubble expansion and collapse. So you're seeing bubbles going from nanoscopic gas pockets that are intrinsic to the media, hit with this ultrasound pulse, and expanding to greater than a couple hundred microns and collapsing all within 100 microns. So this is inducing very large stress and strain and cell displacement. You can see the cells around this collapsing bubble are being pulled into the bubble. And when we went back and did some particle tracking analysis on that data, you can see we see pretty close agreement between those predicted displacement from our models, and at least in the single bubble case, the displacements that we measured experimentally. So our working model is it's really that extent of bubble expansion that's really dictating whether we're going to be exerting enough strain on the tissue in order to rupture the cells that we're trying to treat. And we've also done some work. In this case, this is a high-speed camera. We're actually looking at 1 frame per pulse, and we're scanning the cloud up into this volume. So if you watch cells in this kind of region here, as a bubble comes out, you'll see a couple of those cells that have been bisected multiple times. So when the bubbles hit those regions, they're going to be ablated and kind of pulled in after bubble collapse and lyse. And this really matches well with what we've seen histologically. So here's an early histology image out of the University of Michigan group before I joined that really, I think, was one of the first ever tissues that treated with historypsy. And what you're noticing is that on this boundary, you're actually, it looks like almost like a surgical-like endpoint, like you're cutting it with a scalpel. These are actually bisected cells. So it really highlights the precision. And this all comes out of this non-thermal nature. The fact that these cavitation thresholds are so precise, and the fact that we're not having like thermal spread or other type of energy deposition where you're getting partially treated cells on those boundaries. So one of the first things I did, I got really excited when I was able to join a historypsy lab in graduate school. And the first thing I did was say, what can you treat with hisotrypsy? So I figured I'd throw this up quick because we basically took, some pigs from our other studies, collected any type of tissue that we could treat. And we showed that the vast majority of soft tissues are readily treatable with hisotrypsy. So this is very promising, suggesting that this can be a platform technology that has a lot of utility for multiple applications. However, we did see, and this is something we'll revisit at later points in the talk, that stiffer, stronger, more fibrous tissues are completely resistant to damage. So you see that the tissues on the bottom, things like tendon. I know people here are developing new tools for tendon ablation. Some of the difficulties with that application come from just the mechanical strength of these structures. So we need improved therapies if we do want to ablate those tissues. However, this is actually an advantage for us in a lot of our clinical applications. So when I talk about liver cancer, you'll see that we have strategies now that can be tissue selective. So we can ablate a tumor while preserving these stiffer, stronger blood vessels. So it often works in our favor that we have this differential damage resistant with stronger tissue. So I'm trying to focus most of what or at least half of what I talk on some more of the cavitation threshold and bubble dynamics work in our lab. So I'll be running through a variety of experiments, and all these experiments are using very similar setups where we have a water tank with our different types of transducers and different types of tissue phantoms. So typically we're using mechanically tunable aggro tissue phantoms or some ex vivo tissues that are at the focus of our transducer. And we're monitoring using passive cavitation detection and high-speed optical imaging to look at the bubble dynamics. And as you can see here, this is just an example of one of the setups in our lab with the transducer aligned to the high-speed camera. So the first set of parameters I wanted to talk about is the effects of tissue stiffness on hisotrypsy bubble cloud dynamics. And this, was a big focus of my graduate work that came out of these observations that certain tissues are more resistant to damage. I apologize, this is a very busy slide. This is one of the few where I'm going to talk about both multi and single cycle. But as you can see from the top row here, when we do this shock scattering process, we actually see that the pressure required to generate hisotryptic cavitation bubbles or bubble clouds increases as we increase the stiffness of the tissue. So if we want to treat a tissue with higher stiffness, we actually have to have more pressure. And the reason for this that we've been able to establish is that in order to induce a shock scattering process, you actually have to cause significant bubble expansion of these initial bubbles in order to cause sufficient shock to be scattered in order to nucleate that cloud. The difference on the bottom row, which you're seeing here, is that when we use our single cycle pulses, because we're directly nucleating with the negative pressure phase of the pulse directly, so if we get above this intrinsic threshold, which is really an intrinsic property of water and the water inside the tissue, it's a very distinct pressure from no cavitation to this 100% cavitation threshold at around 25 to 28 megapascal. As we increase our stiffness, you'll also notice we see no change in those curves. So that suggests that it's a different nucleation process and that we can actually have really highly predictable cavitation thresholds when we're using these single cycle pulses in different tissue types. We also looked at some of the bubble expansion. So here's just looking at a still frame at single bubbles. So if we're close to the cavitation threshold, we can generate these single bubbles. And if you move from left to right here, you can see as we increase the stiffness of our aggro tissue phantom, we're seeing a decrease in the bubble expansion. And then moving top to bottom, and I'll talk a bit more about frequency in a few slides from now. But with the single bubble case, we actually see as we increase the frequency, as you'd expect, we have a shorter duration of the applied negative pressure. So you're not growing the bubbles as large. And this is just quantifying that with our T curve here. And again, you see, so increase in stiffness reduces bubble expansion, thereby reducing the amount of strain you're imparting to the tissue. And then decrease in the frequency is a strategy we can take to enhance bubble expansion and potentially ablate some stiffer tissue. If we want to look at it at a higher pressures here, where we actually have a full cloud generated, this was one of the very interesting first findings that we had, that as we increase the pressure of our transducer driving, we actually see that we get a bigger cloud. So we have a larger area that's above the intrinsic threshold within the gel. So we're nucleating cavitation in a larger region, but we're not getting larger individual bubbles within the cloud. And the reason for that, and we've done a lot of work since, we're actually working on a modeling paper right now, is this process of bubble-induced pressure saturation. So you basically get to the pressure, generate the bubble, and the field from the bubble actually negatively interacts with the surroundings. You're always generating that nearly the intrinsic threshold pressure throughout that cloud. So our working model based on this study, after the study, we started seeing that really the parameters that are most important for ablation when using this single cycle pulsing methods are bubble expansion and then the density of the bubbles within the cloud. And one of the parameters that's extremely important for this, and this is something that I think we need more emphasis on when we look at translating things into the clinic, is the F number of the transducer. So how focused the transducer is. You can see here moving from a more focused transducer with a nearly hemispherical design on the top to the bottom. As you notice on the top, we're getting these very dense, well-defined bubble clouds, and those are going to be very effective at ablating the tissue with tryptophan, both from a precision standpoint, but also for efficiency. Where on the bottom, because it's less focused, this beam profile is more diffuse and spread out. We're not seeing as sharp of a bubble cloud. And what that looks like for ablation, if you look at our RBC phantoms here, you see these lower F numbers on the top, how efficient, how quickly you're able to ablate the tissue. Where on these bottom rows, you're kind of relying on bubbles to slowly fill in that focal volume. And you'll notice on the top, it's not only, at this point, it's completely ablated on the top, but it's also more precise. So there's some challenges with using higher F number transducers for intrinsic threshold viscosity. I will point out that shock scattering, and we haven't looked at F number as much, but it's expected based on these studies to have a reverse kind of trend. So a higher F number, you're going to be generating more shock, be able to cause better scattering. So if you have an application where maybe you have a smaller acoustic window and you're trying to target a deep structure, that's probably not going to be an ideal for using these single cycle pulses. One, because you're probably not going to be able to generate that 40, higher than 30 megapascal, but typically about 40 megapascal peak negative pressure we need to get the cloud with single cycle pulses. But also there's this limitation of if you're using the F number, you're going to get a cloud that's not going to be as effective on the tissue. So one of the other parameters we are very interested in is what's the effect of transducer frequency on generating histotripsy. So quick little image of bubble clouds at a variety of peak negative pressures at frequencies ranging from 500 kilohertz up to 3 megahertz. And what we see is as we increase pressure at all of these, we see a larger bubble cloud that really predictably matches the region of our focus that's above this intrinsic cavitation threshold. And as you expect, as you increase the frequency, you see a smaller cloud. So higher frequency, although we're going to have some limits with attenuation for depth, is ultimately going to be better for high precision applications, whereas lower frequency, having this larger volume, is going to allow us for like rapid volumetric ablation to treat tissue faster. We also looked at if we scale these and we do some analysis of the bubbles within the cloud, really trying to characterize that density. What we find is that as we increase the frequency, we see an increase in the density within the cloud, and it scales with the wavelength of the cloud. So the higher frequency is going to generate a denser bubble cloud. But as we saw earlier, so that should lead to more efficient ablation. As we saw earlier, though, the lower frequency is going to blow larger bubbles. You kind of have two competing effects. And when we actually looked at the ablation here, I know it's very fast, and I'm trying to move through without showing all the curves for this, but I have these curves in here just so you can see it a little better. If you look on the right, from those videos, if we characterize how much tissue is ablated as a function of pulse number, we do still see, because of that larger bubble expansion, lower frequencies a bit more efficient, right? So this is, if we look across all these studies we've done on frequency now, we have a pretty good understanding of these trends with frequency. So if you increase the frequency, you're going to see a smaller bubble cloud as well as smaller individual bubble expansion within that cloud. We're going to see an increase in the density of the cloud at higher frequency and a slight decrease in ablation efficiency. And one of the big focuses of my lab right now is kind of how can we develop transducers that can selectively modulate these parameters. So can we selectively change the density of the cloud versus the bubble size, right? So let's say we have a case where we want more efficient ablation. In that case, we want as dense of a cloud and as much bubble expansion. Alternatively, some of the new applications we're driving for are trying to be more tissue selective. So we might want smaller bubbles that only break up weak portions of the tissue, but still want to carve out a large volume. So one of the applications for that we're very interested in, and I have a issue doing some of the first studies on this, is can we fully decellularize like a cirrhotic liver or an ablate and replace tissue regeneration strategy, where we leave not only intact vessels, but all of the extracellular matrix. But the first step to that is having tools that can control cloud size, density, and bubble size separately. So one approach to this has been the development of dual frequency techniques. And in particular, if you look at the waveforms on the left, this is a unique feature of using these single cycle pulses, right? So because we're only concerned about the negative pressure phase here, by aligning our peak negative pressures, we can create these dual frequency waveforms. And you can see here in this middle image and the plot, we get bubbles of intermediate size when we use the dual frequency. I'm not going to show it here, but the citations down there, one of the other things we showed in that paper is by changing the relative amplitude of the low frequency versus high frequency components, we can selectively change the actual size of the bubble. And so that's a nice feature to hopefully we can dial in the size of the bubble expansion. When we look at the clouds, in the case of where we're just driving at 50% pressure with each, we actually see a significant enhancement in this middle case with our dual frequency of how efficient it is. And the reason for that we found is that we're getting a density of bubbles that seems to be dictated closer to the higher frequency component due to the fact that you're nucleating with both, but you're having the bubble expansion from that low frequency component of the wave that's driving larger growth and allowing it to be more efficient ablation. So I'm not going to go into a lot of this just because there's a ton, but I did want to show some images from a paper or a couple of papers that we have in preparation right now. A student of mine, Connor, Edsall, just graduated. And you can see here what we're taking is this dual frequency approach, and we're doing different transducer orientation. So this kind of combines what we did with dual frequency with some of the F number. And you can see the different beam profile patterns that we have in this case is where we have an interspersed elements segmented, where you see kind of the angled shape of that focus. And then our two rings designed with the higher frequency on the outer and then the inner. So the yellow here corresponds to the higher frequency, and then the blue is which is 3 megahertz, and the blue is our 500 kilohertz element. First, looking just at our normal hysterectomy, which I've been showing you so far, you can see here we see differences in the bubble clouds, and it might be somewhat hard to pick some of this out, but you can see here, like on these clouds, a denser bottom region correlated with this more sparse region here, and then front and back, different regions of density, opposite in this case on the bottom. It's easier to kind of see when we use, so these are from our NMH work, so nanoparticle guided histotripsy. And all this is doing it for the purposes of this study is lowering the cavitation pressure. So we use these particles to drop the pressure required from about that 30 megapascal down to 12. And with our current devices, this just allows us to drive with more headroom. And again, you can see in this first case with the interspersed, you see regions that correlate to different regions of the beam profile, have different densities. As we look at our segmented design, first off, compared to the interspersed, if you look how dense that cloud is versus this case here that has a lower density. And again, I'm moving through this quick. We're seeing a lot of correlation with specific characteristics of the acoustic field, and now we're developing models to fully model this. But again, here you see this region that's dense, followed by this kind of sparse density outside. And similarly, this is reversed when we have our 500 kilohertz in the middle. And we have some other really crazy clouds. This is like our hysterectomy Rorschach test, where what do you see when you look into these bubble clouds? But a big takeaway from these studies is that the density really dictates how fast our ablation is. So here's an example. You can see here these boxes. So this is an example from the first pulse, and we've identified regions of high, low, and intermediate density within the cloud. And if we play and you see how this lesion develops, and then the curves on the right show the plots of this, again, what we see in this case is that the regions of higher density within each bubble cloud are ablating at significantly higher rates than these other regions. I expect as we move into tissues that aren't just these red blood cell phantoms with uniform tissue, that these regions with lower density and smaller bubbles there's going to be more tissue selectivity. So that's something we're looking at. Are there certain types of tissues with a higher mechanical strength that just can't ever be ruptured by, let's say, a higher frequency component? And we can utilize this for tissue selective ablation. Moving on to another very important parameter as we advance this into clinical applications, and this is pulse repetition frequency. A lot of the data we do on the physics side is still at fairly low pulse repetition frequency. We can get nice, well-defined clouds. However, and this is really a seminal study that was done in 2012 with multi-cycle histotripsy. As you can see there at 5 hertz up to 10 hertz, we see a lot of these cavitation memory effects. And what this means is as we generate this bubble cloud, these bubbles expand and collapse really quickly. You probably noticed that when I showed that video of the bubble cloud in water. There's all those residual bubbles floating around. Well, those get trapped at specific regions of the tissue. And when you send your next pulse, you're going to just re-trigger those same regions. So this has been a significant problem when we think about you want to crank up the PRF to treat volumetric larger regions of the tissue faster. But unfortunately, we don't see the same per pulse efficiency, and we see a significant decrease in efficiency. So that's what we've seen with the multi-cycle pulses. And we wanted to go back and explore this for single cycle histotripsy. Originally, we had the hypothesis that we would see this exact same effect, but it hadn't really been studied. And here's some examples of bubble clouds from our transducer. So you see a little bit more in these agros phantom, a little more off-target effects at the higher frequency or higher PRF. But interestingly, we see that, the void fraction here, we aren't seeing a decrease in density, and the void fraction is very high across the board on this. And so this, we got to this point of the study, it kind of changed our hypothesis that, okay, maybe these will be effective at ablating tissue, or at least if we're going to have to explain that a little differently. And so here's, these will play fairly fast. So these are, again, more of these RBC red blood cell phantoms. The two first columns here are just showing different time points of the same cloud. So you can see one kind of right after the bubbles are nucleated, and then after the bubbles have been expanded a little more. As we play that here, as you can see, in these top 2 rows at the very low PRF, which aren't clinically relevant, but they're our highest precision. You see very high precision. As we increase the PRF, we're seeing effective tissue ablation, less predictable within the focus, or I should say, less focal fidelity to the first focus. We have seen now with our analysis that there's a consistent prefocal shift of about a quarter wavelength that corresponds to like 1 shock scattering ring that's formed off of it. But what you're seeing from a relevance to volumetric tissue ablation, if we quantify the actual volume of tissue ablated as a function of pulse number, we're not seeing that trend we saw with the multi-cycle pulses. So with the multi-cycle pulses, you see it's significantly less efficient. So this is suggesting to us that we can develop very high rate pulsing strategies for treating larger volumes. One of the applications I'll show you later that this is extremely important, some of the work we're doing with soft tissue sarcoma tumors. We have a veterinary clinical trial in dogs. A lot of these tumors show up at 10, 15 centimeters in size. So actually being able to treat these whole tumors with histotripsy is not practical with any of our current clinical systems. So we're hoping that this finding opens the door where we don't have to do more elaborate arrays for electronic steering and can just directly increase the rate of the therapy. And this is kind of a little side tangent, but since we talked a bit about nanoparticles yesterday, I figured I'd throw it in that as part of our nanoparticle mediated histotripsy work, we do a lot of work characterizing cavitation cloud dynamics. In this case, you're looking at a top row agros phantom that contains basically contrast microbubbles like you would use for ultrasound contrast agent. The middle row here is these fluid-filled nanoparticles, so they're perfluorohexane-filled nanocones that a collaborative of ours developed. And then the bottom row is what I've been showing you so far, just the intrinsic nuclei of the media itself. And we see we can use this to controllably and predictably reduce the cavitation threshold while maintaining the same high precision histotripsy. When we look at the tissue phantoms, though, the ablation, we see a significant reduction in the rate of ablation. So if you look at the left row to the middle row with these nanoparticles, we see almost like 2 orders of magnitude increase in the number of pulses required in order to fully ablate that focal volume compared to our intrinsic threshold case. And this is as a result of the fact that we're lowering the threshold, so it's lower pressure, the bubbles are smaller, we're exerting less strain on the tissue. We recently went back and did this with our dual frequency techniques, and we were able to match what we see with intrinsic threshold. So that approach is working also for the nanoparticles. One thing to note is in the case of these nanoparticles, because they recondense into a fluid, we can keep nucleating bubbles over many pulses, and eventually we fully ablate that volume. Whereas with microbubbles, they're being destroyed in that process. So gas-filled agents this might be sufficient if you wanted to use it for an application where you're just trying to cause some tissue porosity, enhance drug delivery. There's people who propose that for kidney cancer, or for pancreatic cancer, for instance, to break up some of the stromal tissue. But this isn't going to be an approach that's going to allow you to do full histotrypsy ablation where you're left with that homogenized tissue volume. So just to quickly summarize some of what we've seen with single cycle histotrypsy in our parameter studies. I apologize, it's a busy slide, but as I mentioned, the cavitation threshold is really a property of the water inside the tissue. So all water-based soft tissues, regardless of tissue stiffness, have the same cavitation threshold. And we've seen that we can reduce this threshold at higher PRF, as well as keep some of that strong ablation. And one of the big takeaways from all this, I'm not going to read through the whole slide, is that with single cycle pulsing, we can generate very predictable ablation sizes that match the region of the focus that's above this intrinsic threshold. And we can have precise control over the bubble dynamics to develop strategies for treating different tissues. Okay, so we're going to transition here to some of, away from how the bubble dynamics work and talk a bit about our development of histotrypsy for the treatment of liver cancer, which is really the first clinical application that's now being pursued. And so this was work that I started as a graduate student. I was personally very motivated to work on liver cancer. My mom died of liver cancer when I was 4, and it's really just a devastating disease that, there's some treatment options where patients are diagnosed late. A lot of them have underlying cirrhosis. They can't undergo surgical procedures. So we think that histotrypsy can overcome the limits of surgery, chemotherapy, and particularly thermal ablation in the liver that's very vascular, has a lot of blood vessels, very vascularized. You see these heat sink effects that, if you do a thermal-based ablation, especially for larger tumors or tumors in regions near vessels, you're going to get incomplete tumor ablation. So we thought this is a really good application for histotrypsy as an improved non-invasive therapy. So here's an example of one of our first preclinical studies. This is in a pig model. You look on the left here. This is one of our older transducers. It's coaxially aligned with an ultrasound imaging probe. We kind of drawn on so you can see where the ridge on the pig on here. So this is a completely non-invasive transcostal procedure that's applied. And as you can see on the ultrasound image on the right, we're able to see in real time where we've generated this cavitation, in this case, in the liver through the gallbladder. And we're able to generate this with high precision. You'll notice we aren't doing any motion tracking in this case. So it's just free breathing. And even with that free breathing case, we were able to see really high precision ablation, less than a millimeter boundary between treated and untreated tissues. If you look at those, B and C on the bottom here from that case where you have intact, full tissue structure, all that liver, to something that's just completely homogenized into an acellular liquid debris that's fully ablated, no intact viable cells within that volume. This was really the first study where we started to see that we're getting these tissue selective effects. So large blood vessels as well as intermediate sized blood vessels that are stronger than that surrounding parenchymal tissue were preserved after treatment, as well as bile ducts and nerves. So again, mentioned this earlier, but this is extremely promising that this technology can potentially be used in patients that have tumors located in high risk critical locations that would normally basically exclude them from any current therapy that's available for them. So we have a lot of ongoing work trying to develop more tissue selective therapies, and then validating that as we go into different organs, are we going to see tissue selectivity? For instance, is this going to be something we can achieve in one example that we've been working on is cholangiocarcinoma tumors, which is a rare form of liver tumors that form out of the bile duct cells, and they're extremely fibrous. So if they're closer in mechanical strength to the blood vessels and bile ducts, are we going to lose this tissue selectivity in those cases? And we don't have the answer to that yet, and that's studies that need to be done. We also did some early studies looking at, well, you're left with this basically liquefied tissue volume. What happens to that? And so for those, we used a series of different small animal studies. Here's an example of a histotrypsy system under a rat where we're treating the liver, and then we're going to be euthanizing animals at 0, 3, 7, 14, and 28 days to look at what happens to that ablated volume. So here's just the acute case, very similar to what I showed earlier, where high precision, completely ablated, you're left after treatment just basically this hematoma where blood has filled in that volume. And interestingly, what we saw is after only a month after treatment, that lesion was pretty much completely resolved. So this liquefied debris is being resorbed by the body. And this is a major feature of histotripsy compared to other ablation modalities, where you're getting like a surgical-like effect, where you're actually removing the tissue. You're not just killing it and leaving this dead chunk of thermally ablated tissue in there. More recently, and I'll mention this, but I won't talk much about it, we've seen that process of resorption actually is activating the systemic anti-tumor immune response as well. So they're seeing a decrease in untreated tumors as well as the treated tumors. So that's very exciting, all part of this kind of healing response to histotripsy, and that's an active area of research. We also did some early just proof of concept that we can ablate actual tumor tissue with this, because those studies I showed you so far were in the healthy liver. So based on these and a series of other studies, we felt like we were ready to move this into a clinical translation. So as I mentioned, I transitioned after my PhD to work with Vlaisavljevich for a couple of years. This is one of our first clinical prototype systems on the left. Looks very familiar to those of you who use ultrasound carts. It's a cart-based system where we've mounted a mechanical arm with our transducer and a robotic micropositioner onto that arm that allows us to have integrated software for robotically guided automated volumetric treatment strategies. So we went through, did a series of other pig studies, 2 or 3 separate papers on this, showing this idea of treating clinically relevant volumes under robotic guidance, where you're just mapping out a pre-treatment volume on treat, the robot step through. And I've been a big proponent of this because for oncology in specific, it's very important that we're not just debulking the tissue, but killing the entire tumor uniformly, right? You're doing something where you're, we have some work on uterine fibroids. There, you're more interested in debulking. There's a couple cells left, that's not really a problem. With cancer, we always said we need to kill all the tumor. Apparently now this is a big debate because all these histotripsy people with the immune response say maybe we only need to treat half the tumor. The University of Michigan put out a paper that they treated half the tumor in some rat models of liver cancer, and the entire tumors went away just because of the immune reaction. So maybe that'll change, but I'm still a big proponent until that's proven clinically that we should be trying to kill the entire tumor everywhere it is. But that's probably my bias, and maybe I'll be proven wrong. So, but all of that work, really, we saw great safety efficacy data. And so this led into our first clinical trial. This is called the TRISA study. This was done, the PI of this was Joan Vidal-Jové in Barcelona. So this was recently completed. This is a phase 1 open label. Really, the primary endpoint is, can we generate this ablation in a human patient of actually treating human liver tumors, and then look at all the safety endpoints for an early phase 1 first-in-man trial. This is a video of our first treatment from a patient in that trial. You can see here, very similar to what we showed earlier. We see that bubble cloud with high precision aligned with the crosshairs, and we're effectively delivering histotripsy. If we look at, there we go. If we look at a comparison between the treated volume or the planned treatment volume versus this measured treatment volume post-treatment on MRI, you see very close agreement between the spherical volume we've treated around this tumor. So this was a patient with primary HCC, so primary liver cancer. And again, it's a small tumor that we've, it's about 1 centimeter in size, and we've created a 3 centimeter ablation volume with a margin around that. So overall, the results of the study were extremely promising, great safety profile. We treated 11 tumors in 8 patients. You can see some signs on ultrasound imaging of blood vessels remaining intact. We also saw a lot on MRI of intact bile ducts remaining, so that tissue selectivity appears to have translated into the clinic as well. And there were actually 2 cases. So this is a single one of the patients in the trial. But I should have mentioned, so if you look at the MRIs here, you can see all of these tumors in this patient. So as a phase 1 safety trial, loaded with tumors throughout the liver. So this is a patient who has failed all therapies, very late stage, and has to come off rounds of chemo just because of toxicity. So this is a patient you would never see any type of actual clinical response in. So it's very interesting that we saw not treating all the tumors. So every tumor you're seeing on these images from the top here going through is all untreated tumors. So we're not actually showing you what we've treated, and we're seeing a decrease in the size of the untreated tumor. And the fact that this is still a pretty small total ablation volume of tumor that we're treating. So that's very exciting. This is all appears to be immunomodulated. So because unlike thermal ablation or radiation, when we're ablating this tissue, we're releasing tumor-associated antigens and liberating that kind of tissue space for immune cells to come in and activate a systemic anti-tumor response. We've seen a lot of this in preclinical models, but I was very surprised that we saw it in this patient population being so severe. So there's going to be a lot of work, and I think this opens the door for interesting combination therapies with immunotherapeutics, where we can get synergistic effects and maybe drive for actually having treatment options for these really late stage patients. And then, so that trial led to the Hope for Liver trial, which is actually now completed. You can see the newer Hipposonic system in the schematic here. That trial is completed, but the data is not released yet. They're doing their FDA submission, so stay tuned for that. But all signs point positive. I can't comment more on that other than they raised another 100 million. I'm sure they probably shared some of that. So hopefully everything went well, and that company will do good and continue to be collaborators with us and push this into the clinic, starting with liver cancer as this first indication. So overall, we've seen that historypreclinical provide safe, effective, efficiently in the liver. Inducing these systemic responses are a nice benefit as well. And so I just want to end, and I'll try to roll through this fairly quick, because we have a lot of new applications that we're focused on at Virginia Tech in our lab. And just as a reminder, we really view this as a platform technology. There's any, whether it's even in oncology, there's all kinds of applications, but there's other applications all the way out. And I tend to tell people, I think sometimes people think I'm guilty when we're going after tumors everywhere, but right before COVID, I was about 2 weeks away from going to Tasmania to treat Tasmanian devil facial tumors, which is a contagious tumor that's spreading. And I really want to go back and do that. I think our immune or our history cancer vaccines could be great there, but hopefully that shows you like we don't see this as just liver cancer. We think this can go to a lot of applications, but we need more research. We need to understand each tissue specifically and what's the clinical response. So one of the big next applications for us that we've been focusing on is pancreatic cancer. Our collaborators at the Virginia Tech Vet School have developed new pig models. So these are genetically modified models, as well as recent immunocompetent models, where we can grow pancreatic tumors in the pancreas of these pigs with high predictability compared to these other spontaneous tumor models. So this allows us to have a large animal model that we can test actual tumor ablation, have a real target with similar stromal tissue that the human pancreatic tumors have. You don't get that in a lot of cell-based tumor models. And there's just limits of what we can really glean about our targeting devices when it comes to just doing mouse studies. So here's just an example of our history treatments of the pancreas. It's interesting, we had a lot of trouble early on targeting the pancreas under ultrasound guidance, and that's because it's kind of covered with the bowel and intestine, and all of that's filled with gas. In human patients, it's also a problem, but it's easier because you can get them on better fasting regimens, and you can still have them drink. Our pigs don't listen to us to drink. So we've developed this new custard that my collaborator Coy Allen, who's the immunologist who runs this, he makes it by hand and feeds it to the pigs, and it's dosed with so that fills their stomachs and intestines, and then also is dosed with Gas-X and Simethicone and a few things to move bowel gas out. And we've been able to see that significantly improve, and we're able to get this lesion in the pancreas. This is a paper we're working on right now. We also have a feasibility study with our tumor model showing we can target some of those. But more work needs to be done there to really get that fully ultrasound guided approach. And ultimately, I think this is going to probably utilize the pancreas will probably utilize some of our CT image fusion, where we're going to still need that MRI or CT to give us confidence when we go into these first clinical trials. Another big application, this is a study led by Lauren Ruger in my lab, who's about to defend in April. She's been leading all of our work on musculoskeletal tumors. So these are soft tissue tumors that form fairly superficial, but it can be very large, as I mentioned earlier, as well as osteosarcoma bone tumors. So we're partnering in this with our veterinary colleagues, and these are veterinary clinical trials. So these are pet dogs that are coming in like a normal human clinical trial. So we're not euthanizing or using them as research animals. And because of that, we're doing these first feasibility studies are all treat and resect studies. So you can see here, a large tumor on the back of a dog here as we're prepping it for treatment. And then our different steps there where we're doing the treatment. We're letting them sit for about 4 to 6 days in our osteosarcoma studies. or in our sarcoma studies, and then shorter time points, about 1 day up to 7 days in our osteosarcoma. And then they're receiving frontline therapy. So either surgical resection for the sarcoma or limb amputation, which is standard of care for dogs. And even though some of our vets will say like dogs are lucky because they were born with an extra leg, I'm always like, one of our big goals is developing tools for veterinary cancers so that we can have limb sparing techniques as well. And I've been kind of down every time I've seen three-legged dogs around, but I just did a big hike and saw one at the top that was smiling. So maybe I'm getting a little better with it, but still it's kind of morbid. We need to have better technologies like this. So this is an example of our anesthetized dog. You can see this is using the old histosonics platform, but we have a custom transducer and custom robotics that we've added on to that to target these treatments using that same type of approach where we're doing a volumetric ablation. And in this case, we're only treating part of the tumor so that we can do assessments of immune on the untreated tumor. But you can see here on the CT afterwards with the soft tissue sarcoma is very effective. That tissue treated volume is completely ablated. And so very promising results that we're pretty excited about. With the osteosarcomas, we actually did a ex vivo study first. And this is because, as many of you know here who are working on these really fibrous tissues like tendon, we had this concern with osteosarcoma where it has a lot of mineral inside of it. And you can see on the top row is the untreated samples. You can see these mineralized components separated by cells. So it wasn't clear. We've seen we can't treat bone with histotripsy. It's very robust. So what is this osteoid-like matrix? Is that something we're going to be able to treat? Or is that going to be something that's preserved behind? And in particular, what if you have tumor cells that are trapped around these volumes? Are they going to shield it or not? But in our ex vivo study, we saw we were able to completely ablate that tissue. This was a very high dose of 4,000 pulses per point. We've scaled that back, and we're kind of trying to figure out the best dose for these to be more tissue selective, but make sure we're getting all the tumor cells treated. But that was promising. We weren't sure if we'd be able to treat this tumor type. We are, and then we've now done a series of in vivo studies, and I think we're up to like 30 some dogs now in these different studies showing effective tissue ablation, as you can see on the histology on the bottom row here. Where on the bottom right, that's only immune cells. So all the tumor cells have been removed, immune cells have come in. It's very promising that we've ablated the tissue and we're able to generate an immune reaction. However, if you notice on the left, you don't see that bubble clot. So that last image I showed in the sarcoma, everything I've shown you in liver, you can see a really well-defined bubble cloud. In this case, our ultrasound imaging is blocked by bone. And we saw that in, I would say, about 30 to 40% of the patients have more mineralized tissue. So there's like a wide range of osteosarcoma between the soft tissue lytic tumors and the more ossified. So one of the challenges, if we want to keep ultrasound guidance, which is important to confirm cavitation, how are we going to do this when we have blockage of bone? So similar to some of the work that's been done at Michigan for the transcranial system, even though those tend to go towards the MR guided approaches, we're trying to develop more image fusion techniques where we're actually doing transmit receive with our therapy in order to localize where the cavitation is and then do overlays on pre-treatment MRI or CT. So hoping to get some funding for this to continue on to build some of those next generation systems, which right now I don't think we'd have the confidence in how we can target inside of these type of more difficult to treat bone tumors with our system. Another big application is brain cancer. So I mentioned, the Michigan team's developing these transcranial arrays. We've been interested in a few different options for this, but really ultrasound guided techniques for treating brain tumors. Can we do it more portably, safely, easier? One of the kind of reasons for this is I do a lot of, in the last 2 years, we've started this big program in Africa where we're trying to develop technology for low and middle income countries. And they don't have MRIs, they're not going to be able to do these big complex MR guided systems, as well as you're talking about 1,000 element arrays. So if we can develop an ultrasound guided approach, a smaller device that can improve some brain tumor treatments there. And a component of this is I have a collaborator in Italy, Francesco Prada, who's a neurosurgeon, has done a lot of work in ultrasound guided procedures, but he's also developed an intracranial implant that's acoustically transparent. So after brain surgery, you think about you get a primary tumor treated with surgery. Instead of putting the bone back in, you put this implant in, and there's a lot of cranial implants. It is the first one that's acoustically transparent. So it gives you the mechanical strength of the skull, excuse me, but you can follow up with ultrasound imaging. So we've been doing studies with him, showing that we can actually generate different types of focus ultrasound, and more recently, including hisotrypsy, even the highest pressures through this implant, which would allow us to do ultrasound guided procedures. In this case, this is an example. We've only treated 2 dogs to date, but this is a dog with a spontaneous brain tumor that we treated through this open procedure with this small ultrasound guided hisotrypsy system on the bottom left that we constructed. You can see here the precision and how completely ablated that tumor is. So initial safety data looks good on that front, and we have a lot of work that's continuing to push towards brain cancer ablation. Another aspect of this that I'm really excited about, and this isn't limited to brain cancer, but that's their first application. This is a system developed by Jeremy Brown and his team in Halifax, Nova Scotia. And we have a really close collaboration with their lab, as well as they have a company, Daxonics, that's an engineering consulting company that is working to translate some of this. But this is, and I should say their background is really high frequency ultrasound imaging. So in the center of that probe is a 1,000 element, 30 megahertz ultrasound imaging array for endoscopic applications. And then we have this miniature hisotrypsy system we've developed together with them for treating with hisotrypsy at, this is a 6 megahertz. You can think of a super small treatment volume. You can see this is a mouse brain, and looking how small some of these sizes are, being able to carve out, they put their D's in there for Dalhousie to show some of the precision. But I see a lot of applications for this, even though we're interested mostly in non-invasive techniques, things like intraoperative pancreas ablation, ablating lymph nodes, small device like this for oral tumors, things like treating tongue for sleep apnea. So a lot of excitement moving forward with these intraoperative hisotrypsy devices. We do a bit of work in breast cancer, not a lot, but I did want to show this because I'm not talking at all about systemic responses and immune responses. But this bottom plot over here shows, we treated in some of our mouse models, we treat the tumor in the breast, so in the mammary fat pad. And this plot here is showing metastasis to the lungs. You can see in the cases where we treated with hisotrypsy of the primary tumor, we're seeing a significant decrease in the mets that actually make it to the lung. So this is promising that we're, as I mentioned, activating that systemic immune response. Anybody's more on the biologic immune side wants to talk. Clay Allen's my big collaborator at Virginia Tech, who's leading all of the immune work. And I'm getting tight on time, so I'm just going to quickly through a couple final applications. This aligns, I think, really well with a lot of the work that's being done here. We are interested in what's the optimal parameters for fibrous tissue ablation, and one of the things we found when we started to treat, two of the applications are these fibrous prostate tissue as well as uterine fibroid, particularly ultrasound guided techniques for not only killing uterine fibroids like thermal hypo does, but actually debulking them and getting rapid symptom resolution. But as you can see here from our top row, when we use our multi-cycle pulses, we cannot nucleate a dense bubble cloud. It's basically just, these are these tough hydrogels that the University of Washington developed. When we go from agros to those, you can just see this sparse scattered cavitation, and we see a lot of these memory effects. We're just kind of seeing tiny bubbles flickering in these regions and are not really destroying that tissue. But we saw when we use our single cycle intrinsic vessel, we can replicate a denser bubble cloud within that volume. So we were hopeful that this will help us ablate those different types of tissues. We had tried some, so these are ex vivo human uterine fibroids that were taken after surgery. And we had been trying to treat them for a couple of years and constantly failing with multi-cycles. And then eventually we were able to get nice bubble clouds. And you can see here on our recently published study, we were able to completely treat them with hisotrypsy. One thing to note is with this transducer, if you were treating just a soft tissue like liver, you'd be at less than 1,000 pulses, probably less than 200 pulses. So we're talking about multiple orders of magnitude higher dose required. And these fibroids get, my colleague there just took out a fibroid that was, I think, 20 pounds. And it's crazy how large it gets. So we have a long ways to go before we have something that can be used for this. And that's where our recent findings I showed earlier about the higher pulse repetition rate. I'm hopeful that that can advance us to allow us to get something that can actually treat in a reasonable time. But it's early, and we're just happy right now that we can treat these tissues effectively. We've also done some previous work that I'd like to come back to with the thermal mechanical approach, where we try to treat stiffer, more fibrous tissues by first heating with HIFU at a set temperature, and then followed by hisotrypsy And this can cause one of two things. If you're in a normal soft tissue that has collagen surrounded by other cellular components, typically we want to heat at about 60 degrees Celsius. So this causes denaturing of the collagen, so unraveling of that triple helix. But what we find is we go above 60 degrees, that collagen actually contracts. So if we look at the top row, heat at 50 degrees, we can see the tongue sample very well with historypsy, but this contraction drives all the water out of the tissue and makes it really tough. So we actually treat worse if we treat at higher temperatures. The exception to this, which is an application that many of you are working on here, is the tendon application. We saw in this case that because it's basically just collagen and water, you're inducing a hydrolysis effect. So you're basically changing that tendon into just basically a gelatin. So I'd like to pursue more of this at some point in the future. Again, this was very preliminary in a tank. I don't necessarily know, for instance, can we develop that, that type of temperature locally in the tendon non-invasively without maybe some thermal effects off target. So ideally, we would still like to have history be purely non-thermal, but we'll see. Maybe one of these techniques can help in some ways. And the final one I just wanted to show to highlight a non-oncology, non-tissue application is we have a few studies that are going on right now to treat biofilms inside of medical catheters and other implantable medical devices. So we've shown that histotripsy can rapidly remove that biofilm and kill the bacteria. We're very excited about some of our particle-mediated approaches, which will allow us to, we just published a paper on that as well, which will allow us to basically target a catheter with a little handheld device that doesn't require complex image guidance, right? Because you're going to have a lower threshold inside that catheter, scan a large volume, and maybe even you could use that prophylactically for these indwelling catheters that no matter how much biomaterial development we've had, are still getting a lot of infections, and it's a constant problem. So thanks for bearing with me, and I'm probably a little longer with questions, but overall, this is kind of where what we're working on, and at least on the histotripsy front, and where I see this going. I mean, that Hope for Liver trial is now completed. Hopefully that will see FDA approval within the next 6 months here, depending on what happens with the reviews and the company. This week, the Hope for Kidney trial was just announced by Histosonic, so they'll be doing their phase 1 treatment of renal tumors. And ultimately, I hope this develops as a frontline therapy for a lot of other cancers. Pancreas, we think these musculoskeletal ones will be good targets for next clinical work. So, and then, non-oncology applications are hopefully really endless. And I'm very excited to be here and hear about everything else that everybody's working on. So obviously, I want to thank the great team, great collaborators we have at Virginia Tech, our funding sources, and happy to take any questions.
There's time for a couple quick questions, and if you can't get yours answered, I'm glad you can sit around a little bit after.
Take it away. Yeah.
So you're talking about the and you touched on a little bit with the breast cancer, but have you noted any sort of response with metastatic cancer with the liver cancer at all? Like, is it helping with any sort of tumors that have grown outside of the liver?
Yeah, so that was, in our preclinical models we had, right? So the clinical patients, they didn't, most of those patients were looking at the liver, that imaging was all on the liver side. But yeah, we've seen preclinical models, our breast cancer models. The Michigan group did studies of melanoma, liver tumors, and multiple other tumor types. They've also shown synergistic effects for metastatic tumors when they add like a checkpoint inhibitor immunotherapy. So it works better than either just straight histotripsy or just a straight immunotherapy. So there seems to be an interaction there as well. And so we have seen that off target, but also in other organs, particularly the lung and brain. But again, that's an active area that a lot of mechanistic work's going on. And there's open questions to that. So one of the questions is, how much tumor volume do you need? So they've only seen it when, and we've only seen this as well, you treat at least 50% of the volume of a tumor. But that's in a couple mouse models. I don't know how relevant that is. There's also a concern, and this is a big concern for ablation in general, but because of the other limits of other ablation modalities, they don't treat anything bigger than 3 centimeters. So a big question, I'm writing a grant right now, and hopefully we'll get it and be able to answer this was like, what's the maximal tumor volume we can treat in a single session? So some cryoablation has treated 4 or 5 centimeter tumors, and they've seen like systemic, tumor disease from this because they're basically overwhelming their immune response. So this question of, and there's some evidence that, a study that was done in a mouse model in brain had a bit of that effect when they treated a huge volume. So we need to answer that, and we'd like to do that in our dogs with either sarcomas or liver tumors because they form really large, and do like a volume escalation study to say, what is the maximum volume we can safely treat before it's just too much for the immune system? Alternatively, we see a time course to this. So you see for about a month after you do a treatment, the immune system's activated, and then, basically goes back to a baseline. So it may be that fractionated treatments in late stage patients with large tumors is better for stimulating the immune response because you basically reactivate it every month. So I'm very excited about that. It's just a hypothesis at this point. But hopefully we'll be able to use those in some of our larger animals to investigate both the safety as well as, fully created. And we do a lot of in vitro studies, or we don't, my collaborators do, on the mechanism of, is this trafficked through T cells? What's the role of different macrophages? A lot of work on endocellular vesicles. So hopefully we'll learn more and more because a lot of people are studying. Yeah.
I think in the interest of time, if we can do questions afterwards.
Okay, yeah.
Perfect.
Yeah, I have just one question.
One sec.
If you haven't signed in, please sign in on the page here. If you're not a CAD member, students that are here, you can sign up over here to get on a mailing list. Everyone should become members. That's all. Thank you. Great talk.
Thank you all for having us. Raj, you had a question?
Yeah, I can follow up with you later.
Well, I think if you want to ask it now, it's okay.
Yeah, thanks for the great talk. It's a lot of translational work. It needs a lot of funding. So
Yeah.
it's not
Yeah,
just
tell everybody to fund it. Yeah, I'm happy with that. Feel
Yeah.
free to email whoever you want on that front.
Yeah. So the quick question is, like, for the brain tumor ablation work that you showed, right? You were saying that it has like 1,000 element high frequency transducers. So I'm wondering, is the same transducer that is used for, that can be used for both imaging the brain region and also for treating the cancer?
So the histotripsy component of that's just a single element. So if I go back,
Oh, okay, got it.
yeah. So here, can you see my cursor?
Yeah.
So in the center, that square, that's the 1,000 element imaging probe. And then this one here is the histotripsy around it.
Got it. Thank you.
Yeah, no problem. Yeah, and I'm always happy to follow up after too. If,
Sure.
and we can talk about other stuff like we did yesterday. So
Yeah, thank
look
you.
forward to it. Get out.
Thanks for coming.
Yeah,
Great to
thanks.
meet you.
Yeah, it was great talking to you. Yeah, appreciate it. And I appreciate the